Good day. I'm Sister Callista Roy from the Canal School of Nursing at Boston College. Together with the Roy Adaptation Association Executive Board and Fellows, I'm the author of a book, Generating Middle Range Theory, Evidence to Practice. And I'm pleased to bring to you a series of videos with slides that introduce each part of the book. Today, I'm presenting Part 2, Data for Knowledge Development. This will include Chapter 3, Qualitative Studies, Chapter 4, Quantitative Descriptive Designs, Chapter 5, Quantitative Studies that explaining, predicting, and prescribing designs, Chapter 5, Quantitative Studies, Intervention Designs. The organization of chapters on the Roy Adaptation Model research includes 173 studies. So they were put into their chapters, and then within each chapter we had a description of each study, a critical analysis of the study, and then we also started giving examples of research for practice. So that's what you will find within this section of the book. In the qualitative research, first we describe it. An interpretive and naturalistic approach that studies persons in their natural settings, obtaining a clear, complete picture of the person's health condition. These studies can lead to interpreting phenomenon in terms of the meanings of the experience of the person cared for, and this leads to how to help the individual. So I'm going to give you then a summary of the descriptions of the qualitative studies. There were 40 studies, and they are summarized in 4 tables. The tables then are organized by way of the group of the designs. So content analysis has 7, grounded theory 4, ethnography 3, phenomenology was the highest at 17, and then mixed methods and case analysis. The samples for these studies were mainly convenience samples. The numbers varied all the way from 2 in a study to 233. Subjects included adults, elders, children, adolescents, nurses, parents, and home hospice patients. The clinical conditions included adolescents, adults, or elders who had physical illnesses, including serious or terminal, bereavement, women during pregnancy and following a stillbirth, mothers or of children with disabilities. Now, looking at the critique of these studies, I'll simply provide a summary of the critique. And again, these were scored from a high of 5 to a low of 1. And there was 2 types of critique. One that addressed specifically the criteria, and then also a place where the reviewer could write the strengths and weaknesses. So the criteria we were looking at in qualitative research were trustworthiness, audit trail, data analysis, and interpretation of findings. With 4 criteria scored 5 points each, the potential scores would be from 20 to 4. In this section, all studies scored from 20 to 16. Therefore, greater than 80% of criteria were met. Strengths included, for example, studies completely described study populations and the settings, as well as circumstances under which the data were collected. They explained the ways in which the data were analyzed to create the themes. Some weaknesses, for example, some studies did not have sufficient descriptive information given to allow the reader to conclude that the interpretations were grounded in the data. The next set of studies were the descriptive, qualitative research, quantitative research. This describes variables and examines the relationships among them. It aims to present an accurate account of given individuals, situations, or groups. Descriptive quantitative research shows that the concepts and relationships exist, but the approach does not determine cause and effect. So a summary then of the descriptions. Quantitative descriptive studies. Here we had 59 studies, and the 4 tables were, rather than on the design, because it's one design, on the focus of the research. We were able, by making our own choices, to pull out 12 studies that dealt with coping processes, 22 that dealt with the adaptive modes, 12 that deal with stimuli, and 10 that deal with group adaptation. So each descriptive table will handle one of those areas. In terms of samples, the numbers ranged from 11 to 782. In terms of subjects used, there were adults, children, adolescents, elders, parents of children with chronic conditions, caregivers, proniparous women, postpartum women, and postmenopausal women, as well as groups, including nurses. Clinical conditions included infertility, end-stage renal disease, cancer, HIV, coronary artery bypass surgery, heart failure, diabetes, epilepsy, multiple sclerosis, spinal cord injury, urinary incontinence, war injuries, and extremity amputation. Now, a summary of the critique of the quantitative descriptive studies, again being scored from a high of 5 to a low of 1 on the criteria, which included validity and reliability, measurement, data analysis, and interpretation of findings, with a potential score again being 20 to 4. In this group, there were 2 studies of the 59 that were dropped, one with 2 scores of 3 and one with 1, 3, and 3 4s. These were below our criteria. The strengths among these studies included clearly identified samples and the use of eligibility criteria, carefully selected tools of measurement, concepts and reported psychometrics of these, interpretation of results matched the findings and provided new insights. And in multi-site study, there was a consistency of method. Weaknesses, for example, were convenient samples. Sometimes size was too small for the aims of the study or the instruments used. Reliability and validity were not addressed for all instruments, and there was an underrepresentation of people of color. Now, studies that explain, predict, and prescribe. We're now on Chapter 5. These types of studies are tied to theories which provide the rationales for the relationships to be tested. To explain is to identify systematic relationships underpinning a natural phenomenon. Explaining is dependent on looking for the pathways of relationships whereby the phenomenon exists or works. Prescribing was less frequent because it depends on knowing the cause. So a summary then of the descriptions of the quantitative predictive studies. In this case, we have 43 studies in 3 descriptive tables. So the tables were organized by the focus of the research. Coping processes equaled 15 studies, adaptive modes 18 studies, and stimuli 12. Samples used, the numbers ranged from 167 to 375 subjects or participants. Within the sample were included children, elders, university students, Taiwanese mothers, ICU patients, informal caregivers, and African American women. The clinical conditions included, for example, end-stage renal disease, cancer, coronary artery bypass surgery, myasthenia gravis, AIDS, chronic obstructive pulmonary disease, cancer, hip fracture, and arthritis. So moving from the description to a summary of the critique of the quantitative predictive studies, again, scored from a high of 5 to a low of 1. The criteria included validity and reliability, measurement, data analysis, and interpretation of findings, as before. The scores then potentially were 20 to 4. All 44 studies were above the level of 80% of the criteria met, and thus deemed appropriate to be used for further knowledge development and the evidence for practice. I would point out that our criteria had to do with whether they would move on to the next step of knowledge development. Strengths noted were that these studies tested, many of them, middle range theory. They evaluated the dynamic relationships among variables and testing of propositions derived from the Roy adaptation model. A few used random samples and many different multivariate analysis techniques. They are rich with insights and provide clear direction for both practice and for further research. Weaknesses, for example, only some studies had enough subjects to actually trim and retest the model. Moving on to the intervention studies covered in Chapter 6. These depend on understanding the relationships among the variables. A nursing intervention is designed and is tested for its effect on the expected outcome. Generally, the researcher uses quasi-experimental or experimental study. They measure the effect of the intervention, the independent variable, on the outcome of the dependent variable. So summarizing then the description of the quantitative intervention studies, the number is 25 intervention studies, and the focus of the research that organizes them is in 4 categories: coping processes, 6 studies; adaptive modes, 11 studies; stimuli, 2 studies; and the nursing process, 6 studies. The samples ranged from 20 participants to 197. They included preterm infants, preschool, pre-adolescent, school-age children, adolescents, adults, elders, and caregivers. The clinical conditions involved included attention deficit hyperactivity disorder, prematurity, depression, chronic illnesses, kidney transplant, cancer, urinary incontinence, and heart failure. So, to summarize then the critique of these quantitative intervention studies scored from a high of 5 to a low of 1, the criteria were the same as with the other quantitative studies: validity and reliability, each of which were described, the measurement data, and data analysis, and finally interpretation of findings. So this potentially then was a score of 20 to 4 for each study. Of the 25 intervention studies, 8 were scored at the highest level, and all but 1 met the expected criteria, and therefore it was not considered for further knowledge development. The strengths in this group of studies included randomized equivalent groups, care taken with measurement. For weaknesses, some authors said that they might not have had an instrument sensitive to the outcomes. Secondly, the length of time of studies can lead to threats to reliability, such as consistency of treatment, including changes of research staff. Secondly, threats to validity, such as history and maturation, can occur. Examples then of use of research in practice in Chapter 5. I will give you one case, one particular example that comes from Chapter 5. The studies that explain relationships of stimuli, that was 11 studies, have implications for practice because they provide new knowledge about dealing with the factors affecting adaptation to common health issues. For example, one finding was health-related quality of life was strongly defined by affective status, functional status, and physical symptoms. Therefore, this would direct the scholar practitioner towards planning interventions aimed at mood, functional status, and symptom management. This is just one example, and throughout the book there will be many. So in closing, the introduction to Part 2, Data for Knowledge Development. This has included chapters 2 to 6 and talked about the 173 studies. Now from these, we will use 52 of these studies based on the Roy adaptation model and select them to develop 5 middle range theories of adapting and coping.